Okay, good afternoon and welcome to this very data-driven session. So we're looking at all the randomized trials because those are the ones that will make a difference in guidelines or at least have that potential of doing that. And I'm happy to say that we do have a very prominent speaker collection here showing data from multiple different randomized trials within the field. So, and I'm happy to have my co-chairs here. Our future president is walking now towards the stage, so Khalid Gaudat is joining as a moderator and I have Professor Tristan Albbrers here with me. So, on that note, we will invite our current president, Ricardo Cohen, who is a very data-driven person, to give us a talk. Without data, you're just another person with an opinion. How can we reach evidence-based metabolic bariatric surgery? Welcome, Ricardo.
Thank you, Paulina. So, my task is to really speak what should we do to generate evidence in metabolic bariatric surgery. So those are my disclosures. Well, evidence-based medicine lies on a decision, and that decision can be made by real-world data experience, clinical judgment, preferences from the healthcare provider and from the patients. However, it centers on evidence. So evidence is the mainstream of clinical practice. How do we produce the best evidence? We have observational studies, real-world data, and randomized controlled trials. So this may be my opinion, but the first author is one of the most prolific authors in the history of medicine, Dr. Nissen. So can we trust observational data for clinical decision-making? No, they do not prove causation or effect. They just generate hypotheses that could be and need to be proven via RCTs. What problems do we have, additional problems with observational studies? In a post hoc analysis, the lack of pre-specified methods allow the investigator to be biased towards himself, even if non-intentional, and this will influence results. So he can speak with a statistician to add the best test to that sample. This outcomes, this is what I see every day, so probably your method is wrong. So it may be unconscious, but it contaminates the results. So why bother with observational studies? Because they may support evidence-based medicine, or when RCTs are too costly for every question, and sometimes, I don't think it's very common today, maybe the only evidence to guide practice. Why do RCTs matter? First, when we don't know what's going on with a certain disease, well, it clarifies the intervention effects specifically and especially under uncertainty. I don't know what's going on with Operation A and Operation B. I need to be certain about the results, and I don't know the outcomes actually. It will resolve expert disagreements. Some may think they're correct, others think they're correct as well, so RCTs will solve this problem. And finally, it will account for alternative causes and risk factors. Maybe there are other influences rather than the intervention that influence the studies, the outcomes. And the other question, or why do RCTs matter, is mainly when we are wrong. First, there are cautionary tales favoring RCTs. The Women's Health Initiative was a trial that the hypothesis was hormonal replacement in postmenopausal women will decrease cardiovascular events. And this is the outcomes of the real RCT. It unexpectedly increased cardiovascular events. So they thought they were right, but they weren't. The other good example among several different is the Accord trial. Well, they claim that as a pre-specified primary outcome that tight glycemic control will improve long-term diabetes outcomes. But in the contrary, it increased mortality. So if we don't know the outcomes, we need to rely on serious data. And the question is, the RCTs, they are in a bubble, it's in a different setting, it doesn't reproduce real life. It does. This is an interesting study where they assess the generalizability of randomized controlled trials outcomes for diabetes in bariatric surgery. So it's interesting that at UCLA, they got 1,133 patients submitted to other operations rather than the sleeve gastrectomy, 1,200 submitted to the sleeve gastrectomy, and they went after the inclusion criteria of two studies, the STAMPEDE study and the diabetes surgery study, Heidi and Showers study. Well, when the criteria met the RCTs endpoints, yes, there was similar weight loss and glucose control in the UCLA series versus the DSS and the STAMPEDE study. So the answer is yes, RCTs are reproducible in real world, in our everyday daily activities in surgery. Then comes real world data and evidence. Real world data comes from our routine practice. And real world evidence is generated by the aggregating all the real world data. Together, they may inform real world effectiveness, safety, and treatment use. However, they're quite different than RCTs. The population is different regarding the criteria for inclusion. The settings are different. One is at a research center, the other is a routine care facility. The outcomes are different. They're specified in RCTs. Data is protocol-driven, like compared to routine records and claims. The size is smaller in RCTs. It's very large in real-world data. However, they cannot, in observational study in real world, do some causal inference. So there is bias sometimes in real-world data. And real-world evidence is a very useful instrument for external validation of RCTs, and they do not replace RCTs at all. So sometimes we hear, well, real-world data is here to stay. It is, but it validates what was generated by RCTs. And the question that I always have when I present this, RCTs doesn't change medicine. Yes, they do. Look at the SELECT trial. This is a SELECT trial with semaglutide where they show a decrease of mortality after the use of semaglutide 2.4 milligrams. It changed the label of the drug. So it changes the real practice every day. So that's why robust data is very, very important. And I'm ashamed to show this slide, but look how was the perception in a recent past of research in surgery. Surgical research or comic opera. Questions, but few answers. The numbers seem impressive on paper, but they add up zero to science. We changed. We have today RCTs that prove glycemic control. Here the RCTs for glucose control with at least 2 years of follow-up. We have non-glucocentric outcomes in RCTs. You don't have cardiovascular mortality so far. It's an ongoing study, but you have kidney outcomes, blood pressure outcomes, liver outcomes. So yes, we are doing a good job. We maybe changed the image that we used to have. And all of a sudden, we do have some new drugs coming up. We have tirzepatide, we had semaglutide, there are triple analog coming out in 2 years, and surgeons or metabolic surgery underwent an identity crisis. So surgeons look at tablets with over 25 total body weight loss, monthly injections coming out, SELECT trial with cardiovascular events. So the surgeon gets all the intestine and start thinking, I need to do something with the intestines, unfortunately from other persons. And novel surgical proposals without robust evidence for safety and efficacy won't cover us from the rain. So calm down, get your ball inside the cavity of, remember, we are doing things on other people. If you want to do it yourself, go ahead, but don't do this to others. And how metabolic bariatric surgery is sometimes practiced. Sometimes it's a very delicate way to say. Eminence-based medicine, web evidence-based medicine, maybe YouTube-based medicine. This is a problem. Everybody does it, so I'll do it-based medicine. This is the worst one. In my hand, it works. Evidence-based medicine. And maybe conference-based medicine. I heard it at IFSO in Santiago. I'll do it tomorrow. But data is wonderful. This is the SADI sleeve. I see one of the co-authors sitting at the audience, François Patou. And they compare SADIs and the Roux-en-Y gastric bypass. Is the hype around studies justified? So I keep listening. Studies is great, studies is good. It may be good, really. But is the hype around it justified? So first, the weight loss paradox. Yes, there is weight loss superiority with studies, 76% versus 68%, but it did not translate into better diabetes remission or any health gain. Second, there's some study limitations. A high dropout, 20% of missing data, mostly in the studies patients. I don't know exactly why. Short follow-up time, 2 years is insufficient from long-term assessment, and this is reported in the paper. There are some key findings after studies. There, again, statistically significant rate reduction over the Roux-en-Y gastric bypass, but again, no further health gains. Our purpose to treat those persons with diabetes and obesity is to promote them health gain. Complications trade-off. Studies got higher early complication rates, including anastomotic leaks. Studies had more side effects like diarrhea, steatorrhea. The Roux-en-Y gastric bypass had higher late complication rates because of internal hernias. And I looked for the information. They really closed all the mesenteric defects, including the Peterson. And there's an important trade-off. Increased complication risk with studies, potential nutrition deficiency and malabsorption long-term, so 2 years is too short follow-up, and it's a complex procedure. My opinion, if extra weight loss doesn't improve most of the critical health problems associated with obesity, its clinical significance should be questioned. So probably weight loss should not be the primary outcome in our studies. We need to change, mainly because after the SELECT trial, they showed that at 9% of total body weight loss, they decreased cardiovascular events and mortality. So the hype is not justified. Statistical superiority of weight loss with significant trade-offs and no clear benefits. That's the beauty of a randomized controlled trial. And we should not forget that we are competing against ourselves. Patients still think that we are lethal, that we kill patients. So our customers think that surgery is too risky. And I strongly believe that innovation is important. And thank you, Paulina, for this slide. This is her laptop that's on that table. Data is greater than opinion. Otherwise, we're going to be seen as cowboys with the limbs in our hands. And while we waste time discussing techniques with no robust data, pharmas are moving fast, and fast. They are all based on randomized control trials information, changing labels, and doing good for their patients. If I can send you a take-home message, this is a flowchart, very complex. Is it possible to randomize? Complex. Do it. So this is the complexity of producing robust data. Can you randomize? Do it. And I wouldn't like the idea that I heard this morning that, well, we in South America do not have funding for studies. I'm South American and I get funded for studies. So it depends on your quality, on the quality of the study you're proposing, you will get funded. Finally, when are randomized controlled trials unnecessary in metabolic bariatric surgery? Yes, there is the ideal framework, and this algorithm, I customize it because it's based to MBS, to metabolic bariatric surgery. So first, is the operation new in principles of surgical technique? Yes. Do a randomized controlled trial versus standard techniques for safety and efficacy. No, it's not. Second question, is there a claim of superiority effectiveness made? This is what you hear all the time. So this was the studies bypass study. Yes, do it and test for safety and efficacy. Is there any significant changes in pre, peri, and post-op care? Any new indication for a certain population? Yes, do it. Do an RCT. The only situation that may be not necessary, and then we would be the exception of the exception, is combining the outcomes from prospective registries, but honest and ethical registry, to achieve, to collect safety and efficacy data. But again, can you randomize? Please do it. Finally, without data, you're just another person with an opinion. Edward Deming was responsible for partial reconstruction of Japan after the Second World War. And people would come into his office and say, I have a plan to rebuild Tokyo. Where's the data? I don't have it. Next. So this is what we should do in metabolic and bariatric surgery. Thank you very much.
Ricardo.
Thank you.
Ricardo?
Yeah, we have a few questions, so thank you. I just lost the battle over data, over not having any data, just for the if so grand debate, which makes me a bit worried. So what do you think we should actually do to convince everybody that it is very okay to do innovation, but you have to do it within the context of research? You have to follow up your patients because we're not to do any harm. Long-term follow-up, we may end up, like you showed, actual malabsorption, which is a complication, not a...
It's not a mechanism at all.
That's not a mechanism, that's a complication. So how do we convince everybody that you actually have to have data? We keep on giving these talks. I think it's getting better, but any other tips and tricks?
I don't have it actually. I must be honest that I think we should keep on saying that we need data, we need data, and we need data.
That's
So
what I
there's
tried.
nothing
That's what I
else.
said, data all the time in the last session.
Yeah.
Okay, Michel.
Yes, I disagree with you on the remission of type 2 diabetes. You know the randomized control trial from Mingroni, Rubino, from Rome Catholic University, which was biliopancreatic diversion, Roux-en-Y gastric bypass, and best medical treatment. And at 10 years, the resolution of type 2 diabetes was 50% with BPD, but only 25% with the Roux-en-Y gastric bypass. So that resolution was twice as much when you involve the ileum. So omissions is also something that we should not be doing.
At the cost of 40% of malnutrition.
We're not doing the BPD. We're not doing the Scopinaro. There has been improvement. There's the Quebec data on resolution of type 2 diabetes that is quite remarkable at 20 and 25 years, which we haven't talked about.
Yeah.
And then that has moved to ASADI, which is a third generation. But let's be honest, Roux-en-Y gastric bypass 50 years ago is not what we're doing today. So also this operation has gone through some evolution. So
Definitely.
to say that the type 2 diabetes resolution in those ileal operation is the same as bypass is wrong.
I think I haven't said that. I think you didn't listen to what I said.
No, I listened. You said
I showed
you
exactly
said that
one
it wasn't-
RCT that
it
says
wasn't.
versus bypass. There's no diabetes benefit at 2 months.
Yeah.
But
Okay,
this is
Ashraf.
written.
Exactly.
It's printed, Michel. I should recommend you to read papers sometimes.
Quick question.
Ashraf, or be
I want to echo what Ricardo said. So funding is not an excuse. You could have a self-funded study. So we wanted to run a Bariclip trial in Jordan. We didn't have funding. Since the patients were paying for it anyway, you can register a trial with the WHO as a self-funded study if the patient is coming and paying for the procedure anyway. And one other thing that I think you want that discussion, at least in my eyes, but a point that I want to highlight that it seems to be a trend now. We create a device, then we try to find a procedure that fits the device.
Yep.
Usually, you should have a procedure and create a device that makes it easier.
that would be a better
Making
sequence.
a loop to the duodenum, that's not a procedure. It's a procedure to fit a device that was created. Thank you.
Okay.
Thank you,
One
Ashraf.
last question.
Very short, Francois.
It's not a question, it's a very long comment. So I would like just to,
Sure.
I know
I
you.
would like just to quote a French philosopher, Montaigne, who says, "Qui veut faire l'ange fait la bête." And in English it goes that whoever tries to be an angel ends up as a beast. And I think that you are here a demonstration that we have to be careful not to be overdoing ourselves with the randomized trial. This is good, but look at what happened with the drugs. The drugs, you have all these randomized trials costing for one of them $1 trillion. Crazy money with a lot of non-very scientific backward to just drive the recruitment and, of course, anticipate the results. So we have to be careful. And I think that it's very good to have randomized trial, and we are applauding Maud and all the colleagues who have done that for now on. But still, I think there is a lot of place for real-world data, for innovations, and I think that's important not to oppose
But I
these two
think
things.
that's exactly what he said,
Yes.
because to
Okay, thank
validate
you.
the RCT results in a real-world data,
Exactly.
that's what you actually need to do. So we need both, but otherwise, if you
Francois,
don't even...
you're reinforcing exactly what I said.
Yeah.
You need real-world data.
That's what I'm saying, Francois. You're actually
Teaching is
saying exactly
redundancy,
what
that's
Ricardo
fine.
said.
I just wanted to make it clear that randomized trial
Yes.
is not the end of the world.
Yeah.
There is other
No,
things,
you have
and
to
I'm
move-
really with it. You know?
That's clear. After that, you need to move on
Okay,
to real-world
sit down,
data, but
sit down.
now we are
So,
moving on to
let's
the...
move on.
Thank you, Ricardo. Thank you very
Ricardo,
much.
One last thing, Ricardo. The medical RCTs are different from the surgical RCTs. If you give a patient 5 milligrams, it's the same dose in Australia and China, everywhere. But for sleeve gastrectomy, you can have the surgeon doing 20 sleeves in a run, and everyone will be different. How would you make up for the differences in the surgical technique in an RCT?
Well, you standardize the technique in a mostly efficient way. This is the way to go. So this is why in surgery, unicenter RCTs work better than multi-center. So we need to be the most stringent to the technique possible. I understand there are personal differences, but you will never hear from endocrinologists that in their hands, SEMA works better than in the other hands. Okay. So
Because
this
it's
is
the
point.
same 5 milligrams. Okay. Good. Thank you.
Thank you so much.
Okay, we'll move on. Now I'd like to introduce my dear friend, Tristan Albbrers, who 25 years ago we were struggling with laparoscopic procedures, and he came to Egypt several times and educated so many surgeons, and he helped start the laparoscopic bariatric revolution in Egypt. And he's having a very interesting topic, the best trial, 2 years results, sleeve versus bypass. Tristan.
Thank you very much, and I'm very honored to be here. Thank you for inviting me, and congratulations to Camilla and the team to drive the conference here. It's very friendly to be in Chile. Those are my disclosures, reimbursement to institution. I'm setting the scene where we were in 2014, where 13-14, we had a more or less 100% Roux-en-Y's in Sweden until then. But then we saw the taking off of the sleeve gastrectomy. And if we see there, you see at the arrow where we started planning for BEST, and then we thought that this is very important because there is something happening that entirely changes the practice we are having. So we need to study that properly. There was a lot of saying about my patients really request this technique. And I just want to reinforce to us as surgeons that our opinion and our preference is the main basis for why the patient has a preference. So I'm not really believing in too much that the patient really wants. If they are well informed, they might choose something else. There were, as you know, for example, Paulina and Ralph, and you will gonna hear more about that, and a Dutch study with previous data in decent sized studies, but it ended up in a name which a little bit of a problem, that you have equivalence between the procedures, and what does I've discussed this with Paulina a number of times. That is a hard expression, but equivalence, that they were similar. So we started the BEST trial in Sweden, and later also in Norway. And we limited to be under 50 in BMI, so 35 to 50, those were the indications. And we excluded those who had a moderate to severe GERD. It was only those having well-controlled GERD with 20 milligrams of omeprazole that we included. And they should not have a known hiatal hernia of more than 4 centimeters. And we have the combined hypothesis that sleeve gastrectomy can be non-inferior to Roux-en-Y over 5 years if it is less than 5% less effective than Roux-en-Y. And provided that it's non-inferior for weight loss, we would have a superiority if that can provide us with a third less substantial adverse events. And those substantial adverse events, they were collected from a kind of clinical perspective where we gather all the things that we consider being tough complications after surgery, irrespective of it's a sleeve gastrectomy or it's a gastric bypass. And patients will eventually be either a 1 or 0. So some data that's been published, and this is out there. These are the perioperative results, and also the baseline demographics, where we can see we randomized, block randomization, so it was a little bit different in number, but it was 878 patients in the sleeve group and 858 in the Roux-en-Y group at baseline. And you see that the demographics are very similar. There are no significant difference in this. And we conclude, after looking at the 30-day events, perioperative and 30-day postoperatively, that any adverse events were 4.6 in sleeve and 6.3 in bypass, and severe adverse events being clavien-Dindel. Sorry, it's missing there, but it's more or equal to 3B, that you needed a general anesthesia. That was 1.7 and 2.7. And there was no mortality over 90 days. So conclusion of the perioperative results, because that's been a quite strong message that it's a safer operation with sleeves, so therefore it's preferred to many persons. But we could conclude that sleeve and Roux-en-Y, at least in this 1,700 patients, could be performed safely and with a comparative perioperative risk. Now we're coming to 2-year outcome, and I ask you not to take photographs of those pictures because they are unpublished, and we wouldn't have them flying around. So these are data on weight loss. There are no significances in this because we didn't want to report significance according weight loss because the primary endpoint is at 5 years. But you can see that there is a good weight loss in both procedures. I'm presenting now the body mass index and the body weight over 2 years. Regarding comorbidities, what we saw is that the thing differing is not diabetes, because that was similar results. Mehowever, there is a significant difference in hypertension, and that can go also with a quite well-known mechanism with Roux-en-Y, that you have better resolution of hypertension with bypass. And sleep apnea was similar. If we go further on, we can see that dyslipidemia was also similar without significant difference. However, dyspepsia, that was reported as dyspepsia, and it was mainly reflux. You can see that it was reported close to 15% in the sleep patients, and about dyspepsia, some type of PPI use was 5% in bypasses. Quality of life, you can see the curves. There are actually 2 curves, both the sleeve and the bypass, as you see, red and blue, but they superimpose. So we have a very similar improvement in quality of life between the procedures. Looking at complications, once again, it's a primary endpoint, so I don't have any statistics on this, but I display the results, and these are the differences between the procedure. And as you can see, there are slightly over 2% severe complications with the bypass, and around 1% with sleeve gastrectomy. Gastrointestinal problems, a questionnaire gives RS on this. There seemed to be a little bit of a difference after 2 years between bypass and sleeves. However, as you see, it's around 3 and 1.5%. Diarrhea was nothing there between, but remember again, it was the reflux that differed. So we had substantially more reflux in the bypass, in the sleeve group. Let's have a look. Okay, I'm pretty good at time. So the conclusions we draw from this data is that there is an excellent short-term, 2 years short-term weight loss. There are excellent short-term weight loss after both procedures. And there seems to be a superior effect on hypertension after Roux-en-Y gastric bypass. There are similar improvements in quality of life. However, sleeve gastrectomy is associated with more dyspepsia, i.e. reflux, and lower risk of complication after both procedures. So how did these results over the way affected the practice in Sweden? And you remember the initial graph I showed you. But this is what happened. You saw from 2014, we planned the BEST trial. And in the beginning of inclusion, we had a hard time to convince patients that they should be randomized because they wanted a sleeve gastrectomy. In the end of the trial, we had a hard time to include patients because they preferred a gastric bypass. So this is how practice can change over time. And we are now at, actually, this year we are at 85-15% for Roux-en-Y and sleeve in Sweden. I will firstly say a big thank to all the BEST collaborators. There are 20 hospitals in Sweden and 3 in Norway that included patients in BEST. And I will finally just to say a little bit about surgical philosophy, that at least this is my opinion, perspective, and this, that I think we have seen a long and winding road for Roux-en-Y gastric bypass, that this was the procedure exposed to laparoscopy when surgery really took off. And we had very much of the learning curve with bariatric surgery laparoscopically with the Roux-en-Y bypass. So we collected a lot of problems in the beginning. The question is, when you get into problems, I think we as bariatric surgeons tend to do when we have problems with something, we change to something else. And this has been the story of bariatric surgery. And sometimes we change to something else before we have evaluated the one we have. What we see now in Sweden and Scandinavia is some kind of maturity, and I label it Roux-en-Y 2.0, where we have found the clues of doing this. As you mentioned, Michelle, that there's been an evolution in how we do Roux-en-Y nowadays, and this is probably where we should compare. And my perspective, but just looking at the history, I think 10 years ago, the question for many was, why not a sleeve? Because it's almost as good in terms of all things as a bypass. In Sweden, we have come to a little bit more, why a sleeve if a bypass produces better results? Thank you very much.
Thank you very much, Tristan, for bringing your unpublished data here. And we can take questions. Maud?
Yeah, thank you, Tristan, so for your great talk. So my first question is, don't you think that the slide that you show where in Sweden you do more and more Roux-en-Y than sleeves rather than the opposite a few years ago is how you present the surgery? So is it your trial that you didn't publish, that you this is the data of your trial that you didn't publish, that you interpreted, and so you changed the way you present the surgery to patients? So are you more confident with the bypass, and do you present the bypass?
Yeah,
I
I appreciate the question, and I think it's very good. I think that it is so that there were some clinics, very few of the clinics said that they presented the study so that we have the standard, and if you want to have a sleeve, you will need to participate in a randomization. Most of clinics didn't do that. I think it was just 1 or 2 things. One thing also that is happening that we saw 10 years ago, that there was always a Roux-en-Y patients at the ward, 1 or 2, and every morning they reported about that there was 1 Roux-en-Y. This is not happening anymore in Sweden. I don't say that we don't have problems because I'm taking care of them, but that's a small segment, and I think that the surgical community has been much more confident with the Roux-en-Y 2.0, that we can deliver something safe and not unpredictable. But what's mainly driving this, I must say, has been the social media among patients. So that it used to be 10 years ago that, oh, you shouldn't have a bypass because you get all those complications. But sleep, that is a fantastic news. You just limit the size of the stomach. Going to where we have seen those having reflux and maybe weight regain, and we are now seeing that the requests from patients, Stockholm would be the fastest changing thing, but the hospitals, they say that there is no request for sleeve gastrectomy anymore. Patients don't ask for it.
And a short question, do you really think that Roux-en-Y gastric bypass 2.0 eliminate the risk of severe hypoglycemia, the risk of abdominal pain, and the risk of internal hernia?
That's absolutely my aim, Maud. and I have some data in adolescents showing that if we do the 2.0, they have exactly the same GSRS outcome after 2 years as non-operated. So I do think that we can do that. I'm not saying that we're coming down to zero, but I think there is a room of improvement, which is a little bit of the all of you that know me knows that I'm talking way too much about the JJ. But the JJ is what differs one anastomosis from a Roux-en-Y. And the problems with the Roux-en-Y usually comes from the JJ.
Thank you, Torsten. And
Last one.
I think Maud's question was really good because it is very hard in a trial. You have to present the information to the patient as unbiased as possible, and that, of course, applies to clinical practice also. Thank you, Torsten, very much. We will continue with the next one. So then the next presentation will be from the SM-BOSS trial, 10-year results, sleeve versus bypass. And as Professor Peterly has multiple RCTs, so this is going to be presented by Marco Butcher, who's part of the SM-BOSS study group. 10-year data that just came out recently. Marco, please.
Well, thank you very much for the kind invitation, and I would like to pick up the point that you mentioned, that this trial was initiated by my dear friend and colleague Ralf many years ago, and he allows me to stand on his shoulders by presenting this. So I'm talking about the 10-year data of the Swiss multi-center bypass or sleeve study, the SM-BOSS trial. It's a multi-center trial conducted in 4 centers in Switzerland, Basel, Zurich, Bern, and St. Gallen. The primary endpoint at that time was weight loss, defined as excess BMI loss after a period of 5 years, and it was designed as a comparative trial, not as an equivalence trial, so it was designed to find a difference. Secondary endpoints included the reduction of comorbidities, quality of life, safety, and sub-studies were also conducted to investigate the underlying mechanisms. At that time, gut hormones were of greater interest. It was funded by the Swiss National Science Foundation and by Ethicon Endosurgery. To start with the background, you know, and that was like more than 10 years ago, even more the case, that there were different operations at hand that differed not only in safety but also in effectivity. And the more effective a procedure becomes, usually the more side effects you buy into. And that's true basically in all fields of medicine, right? Whenever you escalate therapy and you replace a former therapy with a more effective therapy, it's usually the case that you actually buy more complications or side effects with it. Why should it be different for surgery? However, the safety profile is different, and in a time where we observed a change from historic preferences for the bypass that used to be replaced by the sleeve gastrectomy as shown by Torsten, you could see differences in the US, with the sleeve gastrectomy being the predominant operation, at least until 2021, and the bypass being operated only in 1/3 of the patient. Not quite as extreme numbers in Europe, but similar tendencies, and totally different in Switzerland. So in Switzerland, we're special. There are 1/4 of the patients receive a sleeve gastrectomy, and 3/4 mainly receive a proximal gastric bypass. Procedures like a BPDDS or even a one-anastomosis gastric bypass represent a very small fraction of the patients and operations being done in our country. This is the flow chart of the operation. You see that in total, in the time between 2007 and 2011, nearly 4,000 patients were scanned, basically, in order to participate in that study. I was thinking about that, looking at the data Tristan presented, who seems to have less difficulties in patient recruitment for randomized trials in Sweden. But I think it's a question of time, because at that time, the perception of sleeve gastrectomy compared to the bypass was much more extreme than it was at the time when you started the BEST study in Sweden, where already quite some data were out there suggesting that the differences between these two procedures might not be as big as they were thought of many years ago. So we ended up with nearly with 110 patients in the bypass arm and 107 patients in the sleeve arm. At baseline, the age was 43 years. The baseline BMI was about 44 kilogram per square meters, and the fraction of patients that had a type 2 diabetes was about 1/4 in both arms, and the 5-year follow-up rate was 95%. We published several interim results of that study. After 1 year, the safety data were presented. There we were able to show that the operation time for the sleeve was significantly lower compared to the bypass, and it seemed as if the sleeve was safer at that time, while the weight loss achieved after 1 year was similar and comparable. After 3 years, the weight loss between both operations was similar. No significant differences in terms of complications, quality of life, or the influence on comorbidities, except for GERD, dyslipidemia, where the bypass proved to be better. And importantly, one of the frequent arguments to support the sleeve gastrectomy is very often, at least that's what you hear also from patients, that you don't have to take vitamins if you receive a sleeve gastrectomy compared to the bypass surgery, which is wrong. In this case, after 3 years, the percentage of patients that required vitamin substitution was similar in both groups. I quickly would like to highlight that meal-stimulated studies to investigate the underlying mechanisms were also conducted. These are test meals in both groups, and comparing the bypass and the sleeve patients, and you could see that in both cases, both operations lead to a very early increase in GLP-1 release. The area under the curve is comparable between these two cases, between these two operations. And back at that time, that was quite surprising, because the study was conducted in a time when the hindgut and foregut theory was quite dominant, and many people could not really explain why the sleeve gastrectomy led to similar gastrointestinal hormonal changes as the bypass. We still don't know why this is the case. One assumption would be that it has something to do with how fast the food gets into the small bowel. 5 years data on weight loss indicated for the primary endpoint that there was, after adjustment for multiple comparison, which means that you do not compare the baseline data with the 5-year data, but you also take into account the data at 1 year, 2 years, 3 years, and 4 years, that after multiple comparisons, there was no significant difference for the primary endpoint between the bypass and the sleeve. However, if you looked at total weight loss or absolute weight loss, that was the case of 29% after bypass and 25% after sleeve gastrectomy. That difference turned out to be statistically significant. Coming finally to the 10-year results of the study. After 10 years, the follow-up rate significantly dropped. That's due to one of the 4 centers that decided not to continue to participate and to deliver data. I'm not going to say which of the 4 countries, which of the 4 centers it is, but it's located in the area of Bern, that's I can say. Looking at the primary endpoint at 10-year data, it's the excess BMI loss after 10 years on an intention to treat population. So in these groups, in the bypass group, or especially in the sleeve groups, there are patients still included that underwent a conversion to a different procedure. And if you look at these two groups, 69 in the sleeve group and 73 in the bypass group, the differences in excess BMI loss after 10 years was not statistically significant between the two groups. However, what you need to know is when you interpret these data is that the sleeve group compared to the bypass group had a significantly higher rate of conversion operation. From the sleeve gastrectomy patients, 32 patients actually underwent a conversion, 50% of those because of gastrointestinal reflux, a third of those due to suboptimal weight loss, and 20% to reflux and suboptimal weight loss. Patients underwent a conversion to a proximal bypass or a bypass with a longer biliary limb or a BPDDS, while in the bypass group only 6 patients underwent a conversion and they received a distalization of the elementary limb, so to say, a distalization type 1 for suboptimal weight loss, obviously. And if you keep that in mind and look at the data again on a per protocol analysis and get rid of those patients that actually were converted in a different operation, you end up with 48 patients that had a sleeve in the beginning and at 10 years, and 66 patients who had a bypass at the beginning and at the end, and then the differences in weight loss become statistically significant with a p just below 0.05. What I personally think is the most important outcome of this study is this slide. So whenever I see a patient, and that brings me back to the question that Maud asked to Thorsten, what reasons basically influence the choice of the patients, I think this slide is something that I constantly mention to my patients, because that's a depiction of how many of the patients initially underwent a conversion operation in a period for up to 14 years. You see that at the time point of 10 years after surgery, about a third of all sleeve gastrectomy patients underwent a conversion, while a little bit less than 10% received a conversion after bypass surgery, and after 14 years, that adds up to 70% of patients after sleeve gastrectomy undergoing a conversion compared to the bypass. So basically, that's what you have to tell your patients. The differences in weight loss might not be that big as anticipated. The safety profile is similar. However, if you decide to undergo a sleeve, you have within 10 years, 3 times, and 15 or 14 years, 7 times higher risk to undergo a conversion compared to a bypass operation. And that's an important information to know for patients. So if you put that data and these results into perspective with other RCTs after 5 and 10 years' time, which we try to do here, you can see that in all comparisons, usually if it comes to weight loss, if it comes to comorbidities, in some cases it's dyslipidemia, in other cases it's type 2 diabetes, depending on the power of the data, it always seems to be the case that the bypass is slightly better than the sleeves. And the only RCTs where that is not the case is, for example, the RCT from Paulina, which decided to do an equivalent trial, and the differences were, correct me if I'm wrong, the definition was 8% difference, plus minus 8%. Is that correct?
Minus 9 to 9.
Even more. And I'm pretty sure if you would be to redesign that study, you definitely would change that margin at least.
Really?
Yeah, just in case you didn't know. So I think it's fair to say, against this basis of this data, is that we have good reason to assume that in the long term the bypass produces preferable results compared to the sleeve gastrectomy. If we look at other outcome data, again, intention to treat analysis, keep that in mind. There are patients included that underwent a conversion to a bypass operation, especially in the sleeve group. Looking at the development of type 2 diabetes after 10 years, knowing that about 1/4 of the patient in both groups suffered from type 2 diabetes at baseline, you see that the number of patients that achieved remission of type 2 diabetes is bigger in the bypass group compared to the sleeve group, but that is just not statistically significant. If you would change that to per protocol analysis, that might be very well different. However, keep in mind that this study was not primarily powered to allow any firm conclusions to the development of type 2 diabetes. For GERD, this is also not new data and is in accordance with what Tristan showed for his BEST trial. There is a significant number of patients after sleeve gastrectomy that seems to develop de novo GERD. Out of those, how many of these patients actually develop a Barrett esophagitis depends on definitions and on your pathological institute, but that's a problem. And the bypass surgery does not have that problem. There are still patients after gastric bypass who do report to have GERD symptoms, but that number is significantly lower compared to sleeve gastrectomy. Looking at safety and late complications defined as complications greater Clavien-Dindo grade 3B, you could see that it sums up to not statistically significant differences between these two operations. What you need to keep in mind is that the 9 patients that underwent internal herniation revision after bypass, that at the time of when the patients were included, the mesenteric defects were not routinely closed. So many of those patients actually had open mesenteric defects at the time of inclusion, and because that study was conducted before Eric reported the randomized clinical data, a study on closure of the mesenteric defect. So it's fair to assume that that number actually would be lower in the bypass group compared to the sleeve group. Looking at the mortality rate, all 4 mortalities listed in the bypass group were not related to the surgery except for one early complication that led to death, but that was also true in the sleeve gastrectomy study. So to sum up, if you compare these two procedures after 10 years, the bypass seemed to lead to better weight loss data. It's better in terms of comorbidity resolution for type 2 and dyslipidemia, while these data were not statistically significant, but it's definitely better for GERD. In terms of safety, you have to look at different time points. Early on, the sleeve seems to have some advantages, but that turns into the other direction with increasing time after surgery. Other things to consider is that the bypass is a reversible procedure, which is not the case for the sleeve gastrectomy, and the conversion rate, as mentioned, is significantly higher after sleeve gastrectomy compared to the gastric bypass surgery. I'm done, and in the end, obviously, I would also like to invite you to the second most beautiful city in Switzerland, which would be Basel. Just to mention, the most beautiful one is Zurich, which is why Ralf recently moved there. Thank you very much for your attention.
Unfortunately, we're running a bit late from the schedule, so I only have one question because I fully understand, and our trial also had conversion rate, but that is quite a subjective outcome, the conversion rate, because that is, of course, mandated, perhaps not on only objective parameters, but a surgeon-derived joint decision. So could you comment on that?
I can only say that that is true. Yeah.
So maybe that's also, that's related to the practice, whatever you have at that hospital, so that may not be the best outcome for that comparison.
That's a fair point, but knowing that people usually stick to the region where they have been operated and knowing that these decisions are not lightly done, it's still something that patients need to know, I think.
Definitely. Thank you, Marco, and we will move on.
Sorry, we need to move. We are a bit behind the schedule. So I want to call for Ralf Petterli, a good friend and a very good trialist, and we are looking forward to the SLIM trials 1-year results, and this is also going to be unpublished results. So please keep your cameras down for this, and you're welcome,
Yes.
Ralph.
Thank you for reminding me. There are people that are even more strict than Swiss people. These are the Swedes and statisticians. Thank you, Torsten. So I improved in the acronyms of the trial, I think, over the years. So SLIM, I will get that. So you see on my slide, primary procedures, sleeves are becoming rare. So, and you've just seen now the variety of weight loss curves after these procedures, and this is in the bypass, even though we had very much standardized the procedures. So we really had defined length of the segments, alimentary and pancreatic limb. So I mean, that's how much you can standardize a procedure. And so it did not take into account that there is a large variety of the total small bowel. And Roberto Tacchino from Rome, he has measured a number of patients, or more than 440, and came out with there's not a correlation between the weight, but with the height of the patient. So males have longer small bowel than females, but it depends also on the measurement technique. If you use 5 centimeter steps or 10 centimeter steps. In my personal experience in some open BPD, DS, I always had a ruler and I measured all in a similar way, and that seemed to be, when I had to go in again, pretty much reproducible. And in the laparoscopic technique, I think the 5 centimeter steps is the most reproducible method for measurement of small bowel. So how can we improve an existing procedure to have better results? So I don't believe so much into the stoma size of the GJ, so I think the small bowel in that respect is a bit more important. So you can lengthen the alimentary limb, you can shorten the common limb, or you can lengthen the biliopancreatic limb, or you can have combinations of any of these changes. But you always have to know, if you change one segment, it influences the length of the other segments. And so actually, if you want to know what the effect of one segment is, you should know the total bowel length. And by definition, the length of the alimentary limb and the common limb is called the TAL. Basics, sorry. So there is increase of alimentary limb. This is actually the most recent trial that I could find that showed after 3 years with a very long TAL, average more than 4 meters, somewhat better weight loss after 3 years, a better remission rate, but I mean more complications, more nutritional issues. And in my experience, this just does not work. This operation does not cause a better weight loss, but it causes a lot of problems. So I do not think that is the way to go. Then you can look at the total alimentary limb in a meta-analysis by Albbrers Nimeri's group, and they could say that you have a certain better weight loss if the TAL is not too long, or when it leads to a longer BP limb. But in general, a TAL of more than 4 meters is safe and does lead to effective weight loss results. So you can also change or look at the length of the common limb, and I think the shorter the common limb, the more dangerous it becomes. So I think this will probably not be the way to go, but increasing the length of the biliopancreatic limb has been proven effective in the BPD operations. And so there are, if you were talking about increasing the effect of the bypass, you can cite these 2 trials. One is the Elegance trial from Holland. They have 4-year results. Unfortunately, in their trial, the primary endpoint was exactly the wrong one, to have a statistically significant better weight loss, but they did have a better weight loss with a 150 centimeter long BP limb compared to a 75 centimeter alimentary limb, or vice versa. But they did not mention any nutritional deficiencies in their paper, and they were, when I talked to Fritz Behrens, the principal investigator, what he would do better, he said he would increase the length of these two segments, and it would measure the whole total bowel. That's what we had in mind as well. So Jutta Gislason from at the time in Oslo did a trial where he increased the length of the BP limb, but he at the same time changed some other parameters, and he also did not measure total bowel length, and he had a better weight loss but more nutritional deficiencies. And this was also shown in a meta-analysis. So modification of the BP limb can lead to more weight loss, but it also bears the risk of nutritional deficiencies, and none of these trials has measured total bowel length. So there is another registry-based trial, and I think this is also a good way of overcoming the possibility that you cannot do a randomized trial. You can do some registry-based trials which can add to the evidence. So they had like dichotomized the BP limb longer or shorter than 1 meter and made it propensity score matching. They showed also better weight loss, but again, they did not measure in a registry nutritional deficiencies. And if I cite Maud Robert's, or the French trial, the Omega trial, with the 2 meter BP limb in the first analysis after 2 years, there seemed to be more nutritional issues, which then at 5 years did not show anymore. But that led for us to design the trial to have below 2 meters, but a bit longer than the Fritz Behrens trial. So it was 180 and 80, and 80 and 180 centimeters respectively, and measuring the total bowel length. And we did a mouse model reflecting these percentages of limb length, and could show if you make this BP limb very long, the mice had to be killed because they were just really starving. But if you had sham, short, or long BP limb mice, the weight loss was superior for the long limb, and the glucose tolerance test was also. So that is the design of the trial, 15 Swiss centers and Paulina Center. And we try to do it double-blinded, which is not always possible because there's some surgeons do the follow-up, we don't do our own follow-up. And so we had a composite endpoint because we wanted to have the possibility of including more patients to make subgroup analysis. So we have like excess percent weight loss as as a superiority trial, and non-inferiority in terms of deficiencies where the level was not more than 10% differences. So this is the flow chart. We had more than 800 patients included, had to exclude some before we randomized them, and some had to be excluded during surgery. One reason was not being able to measure the total bowel length, or ending up with a too short towel. So that's exclusion reasons during surgery, or if there was not the possibility to perform a bypass, so had to be decided intraoperatively to perform a sleeve. So we ended up with almost 400 patients in each arm, and we have a follow-up rate in this intermediate analysis of about 90%, but there are some patients that will be included secondarily because the data was not complete, so we can add up to some of these patients. So they were baseline characteristics now are very similar in both groups, except the prevalence of diabetes. This is we looked at it. It was centrally generated, computer-generated randomization. Still, you had more diabetics in the long BP limb group. We'll see what that will end up at 5 years when we are analyzing the final data. Intraoperatively, most of the procedures were done by laparoscopy, some robotics, very few conversions. The technique of the anastomosis was according to the center. They did not have to, this part was not standardized, but we measured the size of the pouch and stuff like that. So we have other parameters I'm not showing here. And all but one center did an anticolic reconstruction. So the duration was about 2 hours, including additional operations, including the bowel measurement. But one has to say that more than half of these operations were instruction or teaching operations, and that explains these long operation times. So we would like not to measure every time the total bowel length, because it does take some time. It doesn't take 40 minutes if you have one additional trocar, but still it has also risk, but the risks are really not so pronounced. We had these 2 full perforations and 17 serosal lesions, but they never led to a significant complication within the first 30 days. And the total bowel length was similar to Takino's results, but ending up with if you have a 3-meter long total bowel, these were the ones that were excluded, but if you measure a certain number of patients, you will end up with patients who have a short total bowel length, and if you then take 2 meters for the construction of a regular standard bypass, you will end up with a very short common limb, but most people are not aware of that. So in terms of complications, it was similar between the two. There was no reason that it should be different. And now weight loss, but again, this is preliminary results. I cannot give any statistics to that. The total weight loss was 35 or 34.4%, so it's 1% difference. That probably doesn't make real difference biologically. The distribution was similar, and in terms of percent excess BMI loss, it was 88% versus 84%. We will see what happens later on. And that's why we did this intermediate analysis, to find out if we really have a similar issue like in the Omega trial. We did not have more nutritional deficiencies or issues in the long versus the short BP limb group after 12 months. And the different types of deficiencies did not differ either. So morbidity was similar for both procedures, so I come to the summary. The total bowel length varies, and the measurement itself was possible in more than 93%. It took less than 14 minutes, and it was a low-risk procedure. The weight loss is similar. The nutritional deficiencies were similar. And in conclusion, today we just don't really know which percentage or which is the ideal length of these 3 segments. Is it going to be tailored to certain parameters preoperatively, weight, BMI, diabetes and stuff, or will it be to the total bowel length? The subgroup analysis that we have or plan to do at 5 years will help us to answer that question. And maybe we come out with an answer that in a certain BMI group, we can always make 180 centimeters BP limb without risking any more nutritional deficiencies. But we know if you just do that blindly, we run a risk that we will have nutritional deficiencies issues. And it may lead to better weight loss. But the deficiencies so far have not been increased by this rather moderate type of RCT. Okay, thank you very much.
Thank you, Rob, for very compelling data. We have time for one short question, one burning question. It was a little bit, Ralph, if I take the short question, I felt a little bit disappointed with the data. How do you feel? So, data are data, but you did a lot of work, and it seemed not producing.
If you take these 800 patients and analyze them like this, yes, it is disappointing. But I'm looking forward to the moment where we can really look at different segments, because we have enough patients, enough power to analyze that. And if we can come up, 180 is always good, okay. Or maybe we have to measure and take a percentage of, and that will be the final answer. That's why I'm not so disappointed. But a little bit I agree.
Okay, thank you, Ralph. Then we will move on to the last presentation. And I'm happy to introduce an awesome trialist and my good friend Maud Robert, who's going to talk us about the SADI sleeve trial 2-year results that we just had as an example in Ricardo's presentation. So please, Maud.
Thank you very much, Paulina, for the kind introduction. So today we'll present the results of the SADI sleeve randomized control trial comparing the SADI-S to the Roux-en-Y gastric bypass. So these are my disclosures. So background and current status of the SADI-S. The procedure was described, we all know, by Sanchez-Pernot and Torres in 2007. The first endorsement for the procedure was by the ASMBS in 2016. The procedure was endorsed by the IFSO in 2018. And in the position statement of IFSO updated in 2023, the authors pointed the lack of level 1 evidence as there was no published randomized control trials comparing SADI-S with Roux-en-Y gastric bypass, which is a long-established and validated standard bariatric surgery. So we decided to conduct this randomized trial, which is a nationwide multi-center randomized trial of superiority, comparing the efficacy and safety of SADI-S. This trial was designed in 2017. The main objective was to demonstrate the superiority of SADI-S towards Roux-en-Y for weight loss outcomes using percentage excess weight loss at 2 years. We used excess weight loss percentage at 2 years at the time of designing the trial because it was the most commonly used metric in the literature, and we wanted to be able to compare our results with the rest of the literature. So the surgical technique was a SADI-S or Roux-en-Y as a primary surgery or after suboptimal clinical response of sleeve gastrectomy. And why did we include revisional cases? Because in France and worldwide, sleeve represents about 60% of all bariatric procedures with up to 30% of recurrent weight gain. So we wanted to have to show the clinic that our results would be clinically applicable in real world. So here is the design of the study. We had the tailored common channel as proposed by Torres and Sanchez-Pernot. So for BMI under 50, the common channel was 300 centimeters. And if the baseline BMI was over 50, the common channel was shorter, 250 centimeters. For the Roux-en-Y gastric bypass, biliary limb was standard, 50 centimeters, and alimentary limb was 1 meter and 50. So this is the design of the study. We started in 2018 with 22 high-volume institutions. Randomizations was equal with a 1.1 ratio. Patients were stratified by center, suboptimal results of sleeve gastrectomy, and presence of type 2 diabetes. Inclusion criteria was standard, BMI over 40 or BMI over 35 with comorbidities, SADI or Roux-en-Y gastric bypass as a primary surgery or as a revisional surgery after failure of sleeve gastrectomy. Main exclusion criteria were a history of previous bariatric surgery other than a sleeve, for example, band or Messon's procedure or others, or a history of type 1 diabetes. So 190 patients were included in the SADI-S group, 191 in the Roux-en-Y gastric bypass group, and the last visit of the last patient occurred in September 2023 after 2 years of follow-up. So here is the flow chart. 381 patients were randomized, 190 in the SADI-S group, I told you, 191 in the Roux-en-Y gastric bypass group. We had 23 patients lost to follow-up because of non-compliance in the SADI-S group, 20 in the Roux-en-Y gastric bypass group, so 12% of lost to follow-up. And after exclusion of deaths, pregnancy, major deviation of protocol, we were able to analyze 144 patients in the SADI-S group and 159 in the Roux-en-Y gastric bypass group. So here are the baseline characteristics of the population. You can see that mean age was about 44 years old, mean BMI 46.2. Patients with a BMI over 50 represented 26% of the cohort. We had 21% of patients who had already had a primary sleeve gastrectomy, so who will have a revisional surgery. And we had 31% of patients with type 2 diabetes. You can see that mean HbA1c was around 7.3% at the time of inclusion, and mean duration of diabetes was around 6.7 years. Patients on insulin represent about 31% of the cohort. What was a bit interesting is that you can see that mean duration of diabetes was slightly longer in the SADS group. There was also more patients on insulin, so we did a post-hoc analysis to see if there was significant difference between groups, but no significant difference at baseline during considering insulin and duration of type 2 diabetes. So here are the data regarding primary endpoint, and so percentage excess weight loss at 2 years. These are predicted trajectories with linear mixed effects model. So you can see in red the data regarding the SADS group, in green the data regarding the Roux-en-Y gastric bypass group. The mean difference between both groups was 6.7%, which confirmed the hypothesis of superiority of SADS towards Roux-en-Y gastric bypass at 2 years. As a secondary endpoint, we analyzed percentage total weight loss at 2 years, as now it is the metric of reference for weight loss outcomes. You can see that in the primary analysis, using regression model with imputation, we found around 3% difference of total weight loss in favor of the SADS, and it was confirmed by the sensitivity analysis with the SADS offering 3.7% more total weight loss than Roux-en-Y gastric bypass. Here are the data regarding glycemic control at 2 years. So 36% of the SADS group were still on medication in the SADS group. In the Roux-en-Y gastric bypass, 30%, no statistical significance. Regarding mean HbA1c, 5.9% in the SADS group at 2 years, 5.8% in the Roux-en-Y gastric bypass group, no statistical significance. And regarding remission, we had 56.6% of remission in the SADS group versus 61.5% in the Roux-en-Y gastric bypass group, and no statistical difference at 2 years. Now, let's move on nutritional status at 2 years. You can see that mean albuminemia and mean prealbuminemia were very similar between both groups, and no difference. We had 11.7% malnutrition in the SADS group versus 10.6% in the Roux-en-Y gastric bypass group. Malnutrition was defined as serum albumin inferior to 30 grams per liter and or prealbumin inferior to 0.2 grams per liter, or BMI inferior to 18.5 kilograms per square meter. And we had one rehospitalization because of malnutrition in both groups. Now let's move to the vitamins. So levels of fat-soluble vitamins A, D, E, and B9 tended to be lower over time in the SADS group, but you can see on the graphs that it was still over the normal threshold, which is represented by the dashed line. Vitamin B12 was significantly higher in the SADS group compared with the Roux-en-Y gastric bypass group. Here are data regarding surgical complications. So we had more early surgical complications in the SADS group, 5.6% versus 1.6% in the Roux-en-Y gastric bypass group, which was statistically significant. We had 3 duodeno-ileal anastomotic leaks in the SADS group.
If you look at late surgical complications, conversely, we had more late surgical complications in the Roux-en-Y gastric bypass group, 9.4% versus 1.7% in the SADS group, which was statistically significant, and we had mainly internal hernias in the Roux-en-Y gastric bypass group, bowel occlusion, unrelated to internal hernia, and also 4 acute anastomotic ulcers. So this is consistent with literature data. Now looking at medical complications and early ones, we had 10% of vomiting in the SADS group, probably due to the sleeve. We had more diarrhea, 12% compared to the Roux-en-Y gastric bypass group, but we had more early dumping syndrome in the Roux-en-Y gastric bypass group, 10% versus 4% for the SADS group. And if we look at late medical complications, we had more abdominal pain in the Roux-en-Y gastric bypass group, 14%, and more diarrhea in the SADS group, 22%. Now, specific medical complications related to the procedure. We look at kidney stones. It was similar in both groups, 5%, 4% for the Roux-en-Y. We had more clinical GERD at 2 years in the SADS group, 19%, probably due to the sleeve, versus 8% in the Roux-en-Y gastric bypass group. It was statistically significant. More use of PPI in the SADS group, 18% versus 7% for Roux-en-Y. We had more early dumping syndrome in the Roux-en-Y gastric bypass groups, as expected, 11% versus 5%. It was statistically significant. Overall complications of grade 3, according to Dando-Clavien's classifications, was similar. 18% in the Roux-en-Y gastric bypass group, 13% in the SADS group, not significant. What is interesting is that the reoperation rate was similar, 7% in the SADS, 6% in Roux-en-Y. Mean hospital stay was statistically more was increased. For the SADS group, 4.8 days versus 2.8 days for the Roux-en-Y gastric bypass group, and the 30-day readmission rate was similar in both groups. This is a complicated table just to show serious adverse events in both groups. What is interesting is that there were more abdominal pain in the Roux-en-Y gastric bypass group, more diarrhea in the SADS group, which required hospitalization. So 5 diarrhea, 2 with diarrhea with renal failure, one diarrhea with hypokalemia, so quite severe diarrhea. And we had 5 internal hernia that we saw previously in the Roux-en-Y gastric bypass group. We did a post-hoc analysis to look at the impact of type 2 diabetes and history of sleeve gastrectomy, which were stratification criteria and post-surgery excess weight loss trajectories, because we all know that both type 2 diabetes and previous surgery can negatively impact weight loss. And this is the subgroup analysis with dashed lines representing the overall population data, and the solid lines representing the subgroup data. And what is interesting is that if you look at patients who had type 2 diabetes and who had no previous gastrectomy history, these are the patients for whom the SADS offered the best weight loss, more than 11.7% excess weight loss more in the SADS group compared to the Roux-en-Y gastric bypass in this subgroup, so type 2 diabetic patients with no history of sleeve gastrectomy. We also look at the effect of percentage excess weight loss and the effect of the surgical procedure on type 2 diabetes remission after adjusting for baseline diabetes duration and insulin use, because we saw that there was a slight difference between the duration of type 2 diabetes and insulin use in favor of the SADS longer diabetes and longer insulin use. And what we saw is that there was no effect of percentage excess weight loss on type 2 diabetes remission. We had a higher probability of remission for SADS compared with Roux-en-Y gastric bypass, but it was not statistically significant. We also found that for each additional year of type 2 diabetes duration, the probability of remission decreased by approximately 7%. So the longest the diabetes is, so the less chance you will have to have a remission, which was also consistent with literature. And we also found that the insulin use at baseline was the strongest negative predictor of remission of type 2 diabetes. So as a conclusion, we found in this trial that SADS offered a superior excess weight loss percentage at 2 years than Roux-en-Y gastric bypass. So the hypothesis of superiority was confirmed. We had comparable safety data, no severe malnutrition, under appropriate supplementation and close follow-up. We found more early surgical complications with the SADI, but less late surgical complications with the SADI compared to the Roux-en-Y, and this is consistent with literature data. We found an increased rate of diarrhea with the SADI, less dumping syndrome as expected. So we concluded that SADS is a valid bariatric procedure, especially for patients without a history of previous sleeve gastrectomy and with type 2 diabetes. Thank you for all the teams who participate to the trial, and thank you for the audience.
While people are coming to the microphones to have questions, I want to ask you more. Thank you very much for the presentation. You really turned the study inside out, so you showed all the angles.
Because of the reviewers.
My question to you is, how do we take this forward? Because the Lancet paper was kind of stating that, as you had in your hypothesis, that SADS is superior to Roux-en-Y. And this is about generalizability of a result in a randomized trial. Would you propose that you disseminate SADS as a procedure that should be dominant?
No, I'm not sure, but I didn't show that. But we also look at, in the beginning when we designed the trial. The idea was also to propose something more efficient for the patients who had suboptimal clinical weight loss after sleeve than Roux-en-Y gastric bypass, because we saw a lot of disappointing results for these patients. So in our idea, it was well for these patients with high BMI with suboptimal clinical weight loss after sleeve, study would be probably better. So in this trial, we did not see that. We did a subgroup analysis for BMI over 50, and we found a trend towards better results, but it was not statistically significant. So I was a bit disappointed by all this post-hoc analysis, but finally, what is interesting is for patients with type 2 diabetes and who had no previous sleeve gastrectomy, if they have a quite high BMI, 46, for example, they would benefit more from the SADI than the Roux-en-Y. And I think that this data, we will do another analysis at 5 years and 10 years. We would have data at 5 years and 10 years. We plan that, and I'm sure that I'm not sure, but I hope that the difference will increase.
And just shortly before giving other questions, as you did have a lot more diarrhea and more GERD, would you not be worried? And of course, it's going to be interesting to see how that looks at 5 and 10 years.
All the patients are scoped before having a bariatric surgery in France. So clearly, if they have a Barrett's esophagus or you know, large hiatal hernia, we will not. I think Salias is not a good option.
No, I'm just thinking quality of life-wise also more. Okay, we have two.
We look at quality of life, and it was similar in both groups.
We have two questions.
Michel, Michel first.
Michel first, please keep the questions concise.
Congratulations. It's difficult to do that study at 5 years. And that is the problem of all the randomized control trial we've seen today, the problem of equipoise, meaning that you have enough experience in both operations in order to do them equally. And I know that in France, SADI is not a reimbursed procedure, I think. I'm not sure, but how do you reconcile with the fact that your surgeons were very experienced in Roux-en-Y gastric bypass, but very little experience in the SADI, which is a difficult operation to do, the anastomosis, the dissection of the duodenum. And in Sweden, it was equally the same. They had very few surgeons who were doing sleeve gastrectomy or had 20, 30 cases when they started the randomized control trial. So that brings a problem in the discussion of how to reconcile the unequal experience of both groups.
Thank you, Michel. And
Thank you, Michel, for the question. Well, I'm quite satisfied because finally we had only 3 duodenal leak. I thought that we would have more, and we had an exterior committee, safety committee, that looked at our data, every 50 patients included, to see if we had, you know, too much complications, and if the complications would have been too much, they would have stopped the trial. So finally, I think that the procedure is quite safe, and I think that our trial is demonstrating that.
Okay, then we have Francois, but you're actually one of the authors, so you have a comment, question. There's somebody behind you. But no, it's fine. You can ask it. Or
So it's not a question, it's a comment. First, I would like to
Short.
congratulate the generation of the quadras of the French surgeons, because they do an extraordinary work, collective, together, one after the other. 2 others are coming in the next 5 years, and that's very interesting. Thank you very much.
That's the only way to do it.
My point is that I would like to comment on your question. I think it illustrates the problem with this discussion today, is that primary endpoint here is 2 years weight loss. It is not, should we indicate this operation? The way you ask the question is the problem. I think we have to be very careful. Information is very strong, but it's a very small information for a patient. I have a weight loss at 2 years. Then there is many things that we can know by our knowledge, by our experience and literature. That was my point. I think we have to be careful with the randomized trial.
To include all the outcomes.
Yes. Thank you.
Exactly, composite endpoint. Please, last
Hello.
question.
I haven't seen in any of the studies presented today bone mineral density analysis in long term. Are you going to look at that? Do you think this is important?
We do it in current practice, at 2 years and 5 years, but it was not planned in the study. We look at kidney stones and stuff like that, but not bone mineral density.
Just a short one. If I just add to that, I think it's a valid comment. We are doing that in 400 patients in the 10-year follow-up with sleeve and bypass, hopefully. But another thing that we need to look into, how much lean mass do you lose with different procedures? Because that would be probably the thing we are called on for the future compared to medications, lean mass loss.
Thank you so much for all the speakers, and congratulations on all the trials. Awesome work. Thank you for the audience for active participation. Thank you.